happens to us. So I decided to personalize it, and this is a journey that I take as a loved one who was watching someone go through it. So the woman on the right, your right, is Christina. So this was taken, oh my God, I'm going to date myself. This was taken in 1988 when I was in college. I haven't changed at all. So Christina, my friend Gunjan, and I were best friends from like the first time we met. And it's one of those friendships that you carry through decades, where it doesn't matter how much time's passed. You just pick up the phone and you're just on the phone for like an hour. And you want to visit them. And she was living in London at the time, and I'd known that she just had her second child. And she called me, and I thought it was just to say how he was doing and all this stuff, because I hadn't visited her in a while. But she called me and said, so they found a lump. It was a big one. And I was like, okay. She's like, but I thought it was a blocked, because she was breastfeeding. So she was putting warm compresses on it, she was drinking grapefruit juice, just anything to let this thing go away. But her son wouldn't take that breast. He wouldn't suck on her nipple on that side. She actually didn't go to the doctor, she wasn't that worried about it until she felt lymph nodes. So she was calling me to tell me about this experience, and it's the one point in my life where I thought, I wish I wasn't an oncologist, because I would like to be the friend who doesn't know what's probably happening. But I did. So she was telling me what happened, and she had a biopsy, and it was breast cancer, and the doctor spoke, and she didn't hear a thing. All she heard were the hardest words you guys have ever heard. It's cancer. So this was Christina. Deer in the headlights that were just ringing in her ears. And the doctor talking about surgery, mastectomy, neoadjuvant chemotherapy, fertility preservation, do you want children, what do you want to tell your husband? And she was calling me saying, would you just explain to me what just happened here? It's like, I am 35. I'm not supposed to have breast cancer. What is he talking about? And we came to this. Breast cancer happens in 1 in 8 women. I hate that statistic. Because each and every one of you were the 1 in 8. So that doesn't mean, since Christina got breast cancer, the 7 other women closest to me are safe. They're my 1 in 8. That's not true. Breast cancer runs in families. Best friends get breast cancer. Breast cancer came to Christina. So we know that this is a true incident, but for me and for Christina, it meant absolutely nothing, because she was 1 in 8. This is what I told her. I was like, Christina, it's breast cancer. It's in your breast and your nose. No one dies of that. No one dies of breast cancer that hasn't tried. And she breathed her first sigh of relief when I said that. Because I learned something very important from that experience. When someone sees me with cancer, the first thing I usually say is, you are not going to die. If I thought you were going to die, tell me. So I told her, no one dies of breast cancer, Christina. We die of metastases. It's when that cancer spreads to the liver, the lungs, your spine, your brain. They die of treatment. They die before we had the growth factors. I remember dying from wiping out their bone marrow, septic, in an ICU. The treatments I was trying to get to cure. And it still happens rarely in the US, but you think of other places in the world, women don't make it. It's not because of cancer. It's because of treatment. And for the vast majority of you, you will not die of breast cancer. You're going to die of a heart attack in your sleep. You're going to die of old age. You're going to die of diabetic just like you have to deal with everything else. And I told Christina that we actually understand breast cancer better. We're in the era where we're not treating everyone's breast cancer is the same. No one in this room will have a breast cancer or a breast cancer experience like the person you just met. Part of that is because the biology is so different. This figure, which I have to look up 3 times to sort of explain to you, is the genetic, the DNA in your body. And all those lines are everything that can go wrong. All those insertions that make a gene malfunction, all those mutations that makes genes go completely crazy. This is what we're understanding about breast cancer. This paper, this figure, is now almost 20 years old. It was a seminal paper which led us to recognize there is such a thing as triple-negative breast cancer. Then we know that there are 2 types of hormone-positive breast cancer. Luminal A, luminal B. We now understand HER2-positive breast cancer is a totally different disease. And we're learning that even within triple-negative breast cancer, there are subgroups of triple-negative disease. So as we're learning about this community, we're learning that breast cancer is as individual as we are. It's a challenge, but it's a chance that we will cure table by table by table by not treating everyone the same way. But biology isn't enough, and this is what I spent so much time in that one moment and afterwards going through with Christina, because she was studying to be a biologist. She was getting her PhD when this happened in London. So she was going through data. She was going through the papers. She was trying to understand the recommendations. And I was trying to help her understand it myself. But I was trying to couch this into what she valued. What was her preference? She wanted to stay in school. She wanted to be a mother to her kids. She didn't want to be hospitalized. She didn't care, though, about her hair. So we talked about all of this, and she just really was she was struggling about what approach to take. And I didn't want to tell her my own fears for her as a doctor, and I was trying to support her as a friend, because I think the worst position I can ever put somebody in is to tell them something that their doctor didn't tell them. Because I had to remember I'm her friend, not her doctor. And if I go against her doctor, am I really going to help her? So I made a conscious decision not to insert my medical opinion and tried to explain why her doctor was recommending a certain thing. But the roadmap is incredibly complicated. Surgery, mastectomy, axillary node dissection, or neoadjuvant chemotherapy, with the hope she won't have to have such an extensive surgery. Fertility preservation was a chemotherapy that affect her ability to become a mother in the future. She had 2 kids, but she dreamed of having 5. She was a Catholic. If she did neoadjuvant chemotherapy, was she going to accept a standard? Oh, well, everybody gets this. I just told you everyone's disease is different. But when it comes to the neoadjuvant chemotherapy part, we kind of take what we have, and it's what you get. So the question was, should she do that? Or should she do a trial? There's no right or wrong in any of this. That's really complicated. I don't have to tell this group that. But I learned seeing her struggle in parts of medicine that I don't see. So what Christina ended up doing was a neoadjuvant chemotherapy trial in London, which I supported. I thought it was... Well, I think you can see me from here, so it's okay. So she ended up doing neoadjuvant chemotherapy on a clinical trial, supported the idea because she had a hormone-positive breast cancer that was not HER2
expressing. And those, for a young woman, are the ones that scare me the most. So I wanted her to do something different. She did not preserve her eggs. She felt she was lucky to have 2. And at that point, she was going to leave it up to the gods, leave it up to God, as to whether or not she was going to be able to have a child after this. So she made that conscious decision herself. And she went through her treatments, and there was no change. So after her denaturant chemotherapy, she had that mastectomy, and she chose to do a bilateral mastectomy, which I didn't support. Right? And she had an axillary node dissection, and then she was told she should do endocrine therapy because it was hormone-positive breast cancer, and that I didn't support either. So I told her, we have a trial in Providence. You should come here, do this trial, because you have a lot of disease, and I'm worried. It's the only time I told her that, and she almost hung up the phone on me. Why? I can't uproot my family and travel to the US. I'm in London. You're asking me to leave my family for an experimental treatment? And I told her, I am. And she's like, my doctor, who she trusted at that point, was like, this is what you need to do. And so she didn't travel to the US, she didn't leave her family, and she took endocrine therapy. But it was the only time I inserted myself in her care as a, well, it's not the only time, but it was the first time that I inserted myself into her care, and she rejected my opinion, which is okay. So this was the question after her surgery, and I'm sorry this doesn't project well, but it's the question that I'm sure you've all had. When treatment is over, is cancer ever over? Am I done? Even though treatment's done, am I done with cancer? And what Christina worried about the most, and I'm sure a lot of women here did too, is what if treatment never stops? What if Christina develops liver metastases? What if she's one of those women with metastatic breast cancer who has to live with cancer like diabetes, but not knowing how long that diabetes is going to stay put? Am I a survivor if I have metastatic disease? Right? I'm here to tell you that you are. That everyone is a breast cancer survivor. Everyone is a survivor of cancer once you're diagnosed. And everyone is, including your children, your partner, your parents, your relatives, your siblings. Everyone is a survivor. And I'm also here to tell you that those folks who supported you through your cancer, they were more terrified than you were. Because this is the process that you all talk about, right? The new normal. This is as relevant for women treated for cure as it is for women who are living through that metastatic process. You know why? Because they look for remission. And every time you get it, or every time you have a stable scan, you're asking yourself, what just happened? You just have to ask yourself that question more often if you're living with metastatic disease. So it's a process. It's the question of what just happened. It's a redefinition. Right? You are not the same. Christina wasn't the same after her breast cancer. So how does she fit? How does she fit back into her marriage? How does she fit back into her kids' lives after they've seen her lose her hair? How does she readdress school in this time where she's not thinking as clearly as she did before cancer? How does she study if her memory's not as good as it was? The new normal is also, though, an understanding of you just survived the worst thing that you could possibly think of, and that makes you pretty damn strong. And you know that strength is internal, it's from above, but it's every single person sitting around that table with you. And we heard a wonderful, beautiful woman stand here and say, it was an evolution. She is a different person. She's a stronger person. She's a business owner. She's changed, but not changed. She's evolved. And all of you have done it already. This is what the new normal isn't, and this is what I actually explain when I meet with couples who are struggling with intimacy. It's not instantaneous. You don't walk out of cancer room and join real world in the room next door. That's not possible. But so many women after treatment's over feel they've got to do it. And when they can't, it's depressing, and it's devastating, and it's confusing. So we as your providers need to prepare you for the process of survivorship. It's not celebratory. Although your partner, your kids want to throw a party for you, they want to bake you a cake, they want to have balloons, right? Because you're done with your treatment. They weren't with you probably when you met with your doctor and said, I want to see you every 3 months for the rest of your life. We're going to get scans. We're going to get blood work. We're going to check. What's there to celebrate, right? When you have to make cancer a part of your life. It certainly isn't easy. And this is probably the hardest part because so many of the people around you were probably hanging on to that thread of hope that it was going to be over. So when you're done with that last IV chemotherapy, they've just got to get out of that room. And that's where the fear and the anxiety comes from. Because as much as you want to go out of that room with them, that room keeps calling you back in. And you just hope that door's not locked. The new normal it used to be, we talked about how long it would be to return to normal. They never go back to normal. Women with cancer are transformed. Looking for that place where you can do that run, you can do that crossword puzzle, you can finish that course, is going to be harder. That's the reality of cancer. So the new normal is a lot of things, and it's something that you go through even if you're living with metastatic disease. It's that fear it's going to come back. It's, what has this done to my body? Why can't I shake the weight? Why can't I feel my breast? It's about intimacy and sexuality. It's about fertility and parenthood. It's about healthy lifestyles. And I want to make sure women living with metastatic disease understand there is a conversation for you about healthy lifestyles. It's not all about palliative care. It's about opportunities and the lost opportunities. It's about financial toxicity and the threat of bankruptcy. And you need to understand that fear of recurrence inside you, that voice that's telling you when is the shoe going to drop on the other side, is not something that just happens to you. It happens to the people around you. So caregivers are probably even more afraid of your recurrence than you are. And if you want to know, am I one of those people who are going to suffer with fear of recurrence? This is the room we worry about. Younger women diagnosed with cancer, women with kids, women living with limited support, and yeah, women with stage 3 and 4 breast cancer. Okay? I bring it up because we can do something about it. We can keep it in check so that you are not paralyzed by it. And there's data that if you want some help, you can get some help and you can move on and you can silence that voice so you can do what you need to do. So this is a study that was just published last year at ASCO, the American Society of Clinical Oncology. It was a psychological intervention they called Conquer Fear. And they compared it to just relaxation exercises. And this was psychological counseling, it was breathing exercises, it was a whole program. And they saw, using standardized questionnaires, which we do in research, that if you went through Conquer Fear, you could conquer fear. Now, you had lower fears of recurrence scores, and it was in check for far longer than that intervention was done. So if this is you, if I've just described you, you need to ask UAB or your own institution to point you somewhere where you can get some help. In terms of body image and breast cancer, these are the two things that we worried about, and Christina certainly did. It was the weight gain, the change in your metabolics, but also, how do I live without breasts? And what was unclear to me in my first few years of practice, and I wonder still if we're preparing our patients well for the process of reconstruction, because that's not just a one and done. So what we did at Brown, we looked at 300 women who underwent a mastectomy, just asked a question: how many of these patients actually went from mastectomy, put in the reconstruction, and take it all the way through? So let's build a nipple and let's tattoo the breast. Look at that last figure. Of 63 women who began the construction, less than 15 had a nipple and an areolar tattoo done. The median time of reconstruction was over a year. So it's a process and it's frustrating, and we understand that. Acceptance is the key to body image issues, and we also know time does heal this. But there was another psychological intervention that was evaluated to see if we could help women accept their bodies. Because, as probably you've all experienced, even though someone you love and cherish is telling you, you are so beautiful, when you look in the mirror, that's the person who's most critical. And no one telling you how beautiful you are isn't going to silence who you see reflecting back at you. So what this study looked at was a group intervention. So gathering women who are just struggling with this and talking about it with women who understand what you're going through made you stronger. There was less distress. There was less discomfort. There was less stigma that you're walking around with a big old BC on your forehead. There was less of a lot of things. So find your tribe. Find your tribe. What about sexual dysfunction? I gave a talk last year about sexual dysfunction, that it was really common. It's the third most common issue that women and men treated for cancer complain about. Less than half of them receive care for it. And the consequences with sexual dysfunction is devastating. Partner relationships are affected. It can be associated with depression and anxiety. And we now know, through work from Jennifer Goss, that breast sensuality is a casualty of cancer. Just think for yourselves, how important was your breast as a sensual piece of you that really got you excited for what was coming next? Think about how much of that is lost. So here, it's asking women who underwent these surgeries whether they feel their breast or their chest wall is still a part of their own sexuality. And that maroon, 60% of women have lost the single organ that made them sensual. It doesn't matter if you had a mastectomy with reconstruction or you had a lumpectomy with radiation. Seek help, because sexual health is complicated in women. It's that computer algorithm in your mind that your man or your partner doesn't really understand, but you can break it down into areas there we can actually approach and make it a little bit easier to grasp what's wrong. GSM is basically menopausal symptoms, genital symptoms of menopause. There are a whole host of things we can give. There's a lot of talk about fractional carbon dioxide laser therapy into the vagina. It's being marketed as something called Mona Lisa Touch. Oh, you've heard of it then. Okay. So the only data out there is in postmenopausal women. Okay, postmenopausal women, there's some limited data in women who are on hormone blocking therapy, but the data is very limited. But things you can use, vaginal moisturizers. Estrogen is safe when administered into the vagina. Okay, and that's a statement from the American College of Obstetrics and Gynecology now. It was part of the work that Dr. Menezes mentioned that I did. So there are things we can do for menopausal symptoms. You need to get an exam if you're having pain with penetration. There's a really quick solution if that pain is localized to what's called the vestibule, and it's the use of lidocaine. So 2 things about lidocaine: it doesn't just go swabbing all over everything. You don't want your clitoris numbed. That's not good at all. All right? So you find the vestibule, you put a cotton ball right on the vestibule, and it numbs it up, but you still feel what's happening. And in a seminal study, 95% of women who are avoiding intercourse because of pain were fine with it and were able to do it. And you can tell your partner, no, your penis isn't going to be anesthetized either. Right. And I know at least one of you had that question, so I'm just going to tell you it's not going to be anesthetized. All right. There's a whole other things, but again, there is help. I'm sorry, are there kids? I'm sorry. But I did say penis. It's a scientific term. All right. So here's the other thing, and I'm glad that this was mentioned. So fertility is the issue as well. Women are not done with kids. Breast cancer doesn't care if you've had your family yet. But fertility has to be discussed before treatment. But questions do arise after treatment. Can I even get pregnant? What about breastfeeding? Can I even breastfeed my child? Pregnancy after breast cancer is not only possible, it's safe. It's not a risk factor for death, although not for death from breast cancer maybe. But it's not a risk factor for breast cancer coming back. It doesn't say if you get pregnant, you're going to die quicker from breast cancer. It's not a risk to your kid. Just because you got chemotherapy doesn't mean your kid's going to be born with, like, horns. All right? There's a thing out there that we learn. It's called the healthy mother effect. It's fascinating. If you attempt pregnancy after breast cancer, you carry your child, and you deliver that child, you're more likely to survive your breast cancer. And it tells you that you are healthy. God telling you that your body is fine and healthy. That's the healthy mother effect. Pregnancy, successful pregnancy, 40% reduction in the risk of death. Children do not have malformations with the sole exception. We have no idea what biological treatments are going to do, like monoclonal antibodies, like Herceptin. All right. So the guidelines with people who with HER2 positive breast cancers is usually wait 2 years after you finish Herceptin before you attempt it, and at least use contraception while you're taking trastuzumab. All right. So it's fine to have a baby. But what about breastfeeding? So I write a blog. Karen mentioned I write a blog on ASCO Connection, and someone reached out to me and said, I was able to have a baby. But, and I met with the nursing, the midwife who does nursing education. She was helpful. She told me how to breastfeed my kid. She gave me all these pamphlets. I'm not in those pamphlets. There's no women here who had a unilateral mastectomy in these pamphlets. Right? I don't see myself in any of the literature they gave me. So I have to wonder, is this me? And this was her quote. As someone who wants to breastfeed, there aren't a lot of resources for women like me. It's frankly hard to find videos designed for the young mother who happens to have had breast cancer. I think this would really be helpful. So comprehensive cancer centers have those resources. Find them. And ask the question. This is what I want you to take away from the lecture. Ask. I want you empowered. In terms of healthy lifestyles, and again, this is relevant even if you're living with your breast cancer, you want to think of it in 3 ways. So yes, there's weight, but it's about food you're taking in and the energy that you're expending. This is what we mean by healthy lifestyles. Remember, heart disease is the #1 killer of women. You don't get a pass from heart disease because you had breast cancer. What does it mean to be active? Walking at least 9 hours a week. Not a day, a week. All right? 50% lower risk of relapse, of death from breast cancer, and a lower risk of all-cause mortality. This is the recommendations of the American Cancer Society. Healthy weight, not underweight, not optimal weight, a healthy weight. Be active for at least 30 minutes for at least 5 days. Eat a healthy serving of fruits and vegetables, limiting red meat or processed meat, and limit your alcohol intake to 1 to 2 drinks a day. Now comes the biggest part of what we're now recognizing as a huge issue, which is the opportunity costs of breast cancer and the financial health of our patients. We are learning out-of-pocket expenses are ridiculous. In a study, $5,000 out of pocket, median, women were having to pay for their breast cancer. Financial toxicity might actually be a really bad risk factor for our patients. So we know that if people were having trouble with their finances in the beginning, when they were diagnosed with breast cancer, that is not actually associated with any bad outcomes. It has no impact on recurrence, survival, or anything. But if your cancer treatment is forcing you into bankruptcy, that's where we need to worry. Because at least in one study, there was an almost 20% higher risk of death if your treatment was causing financial toxicity. It might be because you were not able to do the therapy, right? I can't afford trastuzumab, so I can't get it. Or it might be because you were making really unbelievable trade-offs, right? Maybe you weren't able to afford that fruits and vegetables because you were trying to feed your family. Maybe it was easier to just go to Wendy's and 7-Eleven, right? This is a problem, and I want you to know that folks at UAB and at all the cancer centers, we recognize it. It's a huge problem. We're going to try to solve it with you. But you can do concrete things right now. Learn your insurance coverage. So I have a patient who couldn't afford much insurance. She bought a policy that doesn't cover growth factors. It's not even in. There's no class of drugs that says, I will cover growth factors so you don't die from sepsis when I give you chemo. That wasn't an option. I couldn't argue for coverage. That class of drugs wasn't available to her. We worked with her. We got her free drug. But you got to learn your insurance. Talk to the business office before you get into trouble. Take stock of what you have, what you don't need, and what that 15-year-old can live without. Learn your options if you're employed. Find about your Family Medical Leave Act. Find out about a vacation policy. Find out about sick banks. Find out if your coworkers can donate their time to you. Talk to social work. Keep a record of your expenses. And tell your doctors, choose wisely. This is a mandate that's coming from every society. These are some things you might want to see. If you don't get nausea with your drugs, don't give me the nausea meds. They're expensive. If I have metastatic breast cancer, do I really need chemotherapy in combination? Do you really need to do a PET scan with me? Because I have to pay 50% of that. Save the targeted treatments for biomarker-driven disease. So the most obvious one, if you don't have HER2 positive disease, no one should be recommending Herceptin for you. The new movement, and I'm going to tell you this word because it's loaded, the new movement in oncology is all about value. What you're seeing here is the ASCO framework. They're calculating something called the net health benefit based on the clinical trials of what they saw as benefits in terms of recurrence and mortality, the toxicity, and their cost. You want to insert yourself into those discussions on value. No one's going to be able to tell you what you should value. We need to hear from you what you value. So how do you move forward? This was Christina on the left before she called me. She was suffering. Right? She was trying to solve it all herself. And I told her, if you just looked around you, you'd see you're not alone. The world is empty if one thinks only of the mountains and the rivers and the cities, but to know someone who thinks and feels with you, who though distance is close in spirit, it makes the earth an inhabited garden. So don't go through this alone. Educate, engage, and evolve. I'm not going to read these because even I can't read them. Become a partner for your own progress and for your community's progress. Research is becoming patient-centric. Your voice is needed to design the trials, define the questions, and say how best we can actually do this. Because at the end of the day, just like with Chris, cancer will change you. You're not going to be that 30-year-old, 40-year-old, 50-year-old, 60-year-old woman who's going to sail through life. You just got slapped in the face saying at some point you're going to die. And we're all going to die. But cancer definitely changes you. But life is good. And this is Christina after treatment with her sons and her husband. And I'm going to leave you here, that life will be good again. We can make things better, and we can all be heroes. So thank you for having me.